field. And our first speaker will be Dr. Neil Seymour, Professor of Surgery at Tufts University, working at the Bay State Medical Center, and he's going to talk about, does VR improve OR performance? So Neil, welcome to the podium.
Thank you, Steve Serrano. Thank you for asking me to participate in this great program. I have no disclosures. I'm going to start by dealing with what I think is a foundation strength of VR. If you're dealing with the whole question of generalization or transfer of skills to the clinical operating room, I think you have to start with the concept of VR as a measurement tool. And I mention this as a foundation strength because virtual reality tools developed to date pretty much all share the common characteristic of being able to do very, very sophisticated measurements. If you look at what has been published, again, generally, across multiple platforms, multiple vendors' devices, it's fair to say that at this point in time, VR is associated with a very high level of evidence of being able to express a level of technical skill. So if we look at what the measurement capabilities are and look at the in-lab measurements of people performing these tasks on many different devices, the measurements reflect the expected level of skill in the users. Furthermore, the measurements are done in an objective fashion. The machine metrics don't lie. They measure what they've been designed to measure. The measurements are unbiased. They're done by computer. And at least for some of the measurement types, there is associated reliability and validity based on specific testing. This figure shows the learning curves for a group of resident, the upper curve, and expert surgeons performing a high-level VR laparoscopic task on an older generation VR simulator. And it shows basically that the learning curves diverge and that experts acquire the skill much more rapidly and achieve a stable level of performance at an earlier time frame than the residents, but the curves converge out at approximately iteration number 15 in this case. This is looking at a composite score that's very heavily weighted for time. Some types of measures may be more valuable than others. It's hard to know what to do with a lot of the motion analysis data that's out there, things like smoothness of operation of instruments, path length. Although in many cases these types of curves are observed, it's a little harder to know what to do with that in terms of the transfer to OR side of the equation. So there have been numerous studies looking at educational effects of VR training outside the clinical operating room. So you look at the performance level manifested both in lab using the VR training devices themselves, or alternatively, other types of simulation platforms that might use actual physical instruments and physical objects, and because of that characteristic are deemed much more of a gold standard because we obviously are operating things that are more closely associated, at least in an intuitive way, with what's used in the operating room. Or the animal OR, and in this case, Animate Lab, looking at, again, this is laparoscopic suturing and knot tying in an animal model with a baseline study. This is a subject-controlled trial. In other words, there's no control group. Each subject serves as his own control. And the task is examined in the animal model before and after simulation training. In this case, using a VR simulator, the same older platform training the task. And obviously there's improvement in all individuals looking at the composite video score, that's a video analysis of the actual task, and the time to task completion. So this is fairly compelling, but not quite the same thing as a drug trial-like study design. If you add to that fact, we could actually look at a benchmark level of performance, in this case, expert attending performance on this task performed in the animal OR, that residents can achieve a level of skill associated with expert characteristics, and that's a great thing to target residents to. But you have to say, this is not the clinical operating room. This is done under circumstances where the experimental conditions can be much more tightly controlled. It's a different set of circumstances that can be conducted in a more free and easy way than actually doing this in the OR. So that takes us the type of study that really allows us to look at skills transfer. And that is a drug trial-like study design looking at a clinical task performed after a course of VR training. These are the results, actually this is one of the results of the LVR to OR study, which is now 12 years old. I'm really amazed to say that, where a group of 16 surgical residents were randomized to either a course of VR training, to a specific performance objectives, and what I'm going to term standard training. This is actually exposure to the clinical tasks in the course of actual operations and the usual things that we at the time were doing in order to train residents, which the VR train group also benefited from during the study period. The results were pretty compelling. The VR train group performed the procedure 30% less time. There were shorter operations, and 1/4 of the number of tactical errors or attending interventions, what we termed errors, as opposed to the standard train group. And this was the largest area of difference showing the educational effect of the VR. This was something that actually got my attention at the end of the study. It was not what I was expecting. I was a true believer afterward. I said, VR it has outstanding potential to improve resident performance. We need to go with this and develop it further. Slightly different way to look at the OR performance paradigm is a correlation analysis. And this is actually looking at a very specific procedure. This is looking at laparoscopic cholecystectomy. We had a good VR model of excision of gallbladder during laparoscopic cholecystectomy. We had expert performance criteria. We trained residents to those performance criteria and then looked at contemporaneous performance of laparoscopic cholecystectomy for those same residents in the operating room using an institution-specific global assessment tool, and found that there was a fairly strong level of correlation. There were 3 outliers, but for the most part of the 15 residents who were in the study, the correlation was very good. There have been a lot of drug trial-like design studies that looking at the performance transfer from the lab to the OR, and this is by no means a comprehensive list. And I show this to illustrate the fact that the study design, which conducted under the highly orchestrated study conditions that it's worth being able to implement when you're doing an experiment of this type, show pretty much the same thing. If we do this with a study group, and the training is done in this case not just objectives-based but time-based curricula for the VR training, the results are pretty consistently positive. There is improvement in performance. It is detectable in clinical setting. But you have to look at these data very, very honestly and say the actual educational effect is observed across a very narrow range of skills evidenced in the OR. And the number of things that are actually trained and measured in the VR environment is also relatively narrow. So we're looking at something which is not a comprehensive view of OR skills and the ability to perform an operation, but rather where these narrow measures seem to be impacted by the VR training. But where it's been done, the results are positive. I want to point out 3 studies I regard as best in breed. Number 1 and number 3 are randomized drug trial-like studies, but they're based on very, very strong curriculum-based study designs for the VR training and looking at the entirety of procedures. In this case, surgical residents, in this case, GYN residents, also show in a very, very compelling way that the training, again, limited numbers of subjects in these studies, produce very positive results across not just a component of the procedure, but the entire procedure. The second is not an OR study per se. It actually looks at performance in the lab, but again, a best-in-breed look at how curriculum-based training can impact performance. In this case, novice resident operators relative to an expert group, showing how you could actually much more rapidly achieve expert levels of performance, and then at least in theory deliver these residents to the operating room where from the get-go they may in fact do a better job. And actually I could add that in the Larson study that was exactly what was observed. This is in the course of gynecologic procedures. The VR trained group, when looking at the number of operative procedures they had to perform to reach what we regard as a competency level, much smaller number of procedures than the non-VR trained group. So arguably much better use of the OR as a training resource with that supplemental VR training. So now I come to the stickier part. So there have been 2 recent Cochrane reviews looking at this specific question. What is the value of VR in training? I'm going to actually throw flexible endoscopy into the picture here. My apologies to Brian Duncan. I know he's going to talk about this. I'm just going to deal with this in a pretty superficial way. But these studies did show, for the most part, there's a consistent impact on procedure time when looking at these drug trial-like randomized prospective studies, for the most part with some degree of blinding of subjects and reviewers. However, there were some problems. First, small number of trials for review. In the case of the VR endoscopy, 13 and 8. These were the number of studies that met the review criteria. And a relatively small number of subjects. For the endoscopy, 278 and 109. That sounds like it's a recipe, do a meta-analysis. In fact, meta-analysis study design is impeded by the fact that the methodological differences between the studies were so great that actually doing proper meta-analyses was virtually impossible. Furthermore, despite some degree of blinding in many of the studies, the risk for bias was very considerable in most of the studies. And you're looking at the study design, there were some of that may have been preventable, some not. But the fact that the opportunity for bias was there was perceived weakening of the study design. In fact, we're looking at best level 2 evidence. So I put this slide together to look at VR educational effectiveness with different areas of potential impact. First, the simulated performance, and we're talking about in-lab type assessments exclusively, very strong evidence, and lots of data, lots of work that has been done. And on inanimate tasks, looking at some degree of what we would term a concurrent validity of the VR training, that in fact there's some pretty good evidence here as well. And in non-human models, looking at perhaps performance in animal OR or inanimate animal tissue models, performance data are actually pretty good and show an educational effect can be achieved with VR. However, that data diminishes when we move to the clinical operating room, look at performance that is observable looking at the actual operative event. So we're not talking about more downstream items related to outcomes, but looking at things like the Elmas performance. We looked at the VROR study at Yale, just little tactical errors using an electrosurgery device. Was it used accurately? We're talking about things that may not necessarily impact on the quality of the operation as measured by the more downstream outcome, looking at things like morbidity, mortality. But in fact, you can detect clinical performance improvement in this way, and that's what most of the studies have achieved. And looking at more proximate clinical outcomes, the story is as big as it is because I've thrown the flexible endoscopy data in there, and the data are stronger for flexible endoscopy. And then we're looking at things like patient comfort level, or the time to complete the study, where arguably, you do a shorter study, you're evidencing a higher level of skill. The data are better. They're not as good for VR laparoscopy, and everything that I've dealt with so far relates to VR for laparoscopic training, because that is the area of the field where the device development are most evolved, and frankly where these studies have been done. And then looking at downstream clinical outcomes. Now we're talking about the big things, morbidity, mortality, length of hospital stay, cost of procedure, and cost of care of the patient. Things that are associated with increased measurement challenges, in part because the number of things we might be observing here are very small in number relative to the number of observations that would be required to detect them. And that's not really a star, that's a frowny face, because that's That's where that state of data is, unfortunately. So I asked myself this question: why aren't the data stronger? And I asked that from the person who's a true believer. I really think VR has outstanding potential, but the data are not particularly strong, and I think in part it's related to reluctance to use VR. The number of systems out there that are available for study, particularly multi-institutional studies where there's little standardization, we got a lot of different platforms, there are very few, and unless they're used, we're not going to be able to do the studies. The study design challenges, frankly, the drug trial-like study I mentioned, very hard to do. And if you look at the clinical assessment side of the picture, it's particularly hard to do. If you've ever done video analysis and understand what it takes just to do one of those analyses in the proper way with the appropriate scientific rigor, they're logistically difficult studies to execute. I have to ask the question all the time, are we targeting the right measurements? We keep coming up with time as a measurement that seems to work for us, but I know that there's more buried in the procedure and in the VR simulator tasks than some of the metrics that we have. And I ask myself the question, are we doing a good job in choosing the right things to measure to detect these performance changes with the training? I mentioned clinical performance measurement challenges. And finally, limitations of the simulators themselves. And looking at what they train, again, I look at it and I see relatively narrow range of things that are trained, focusing primarily on basic laparoscopic manipulative skills. And there's a big difference between that and learning how to do an operation. And I think that actually speaks to the state of development of our simulators and some of the obstacles to further development that I know are going to be dealt with later in this session. But those are real questions, and they're hard ones to tackle, but I don't think that takes away from the potential of the technology. So I'm going to give you the conclusions that I think it's inevitable that you have to reach looking at what's been published. The VR training devices are very good for the development of rather focused skills based on what we can measure. That there's no conclusive evidence that VR-based training is superior to non-VR alternative methods. I mentioned that, not having covered that in the previous talk, but that's basically what the data say. There are other methods to train that are also effective. And the evidence of VR-based training that it improves clinical outcomes other than some very, very specific observed skills evidenced in the operating room are scant. And you have to regard them as inconclusive, despite the fact that some of these studies are very compelling and do show a training effect. Different training effects, much more convincing and valuable training effects, things that might impact, and I throw this out there, the cost of doing an operation. We're going to the OR with a better trained resident. Those data are currently too scant. I think they're within our reach to get, but at the present time, we don't have them in the way we need them. Now, having painted that picture of the current state of affairs, I wanted to add that I am a true believer, and there's this big however, that VR is currently the only widely available training lab resource that is free from observer bias, so if we're thinking about it in terms of value of its measurements, that can autonomously give some feedback and do some mentoring, although I have to say for the current devices, it's a relatively rudimentary level of mentoring, but it's still there. It's technology ensures a high standardization of the measurement conditions. So if you want to learn something about resident performance, these things will do it, and they'll do it in a very standardized way, much more so than some of the other things that are available to us. And provide abundant iterative training and measurement opportunities. I say with minimal educator input, I don't necessarily want to suggest to you that's an optimal state, but where we want to do iterative training and give in my case, I focus on residents as a residency program director. I want them in the lab. I want them doing these tasks. On our VR devices, once they've had their checkout ride and they actually are not going to break the device, they can log in themselves, and actually we capture all those performance data. We can look at their performance curves, and they can do self-directed practice in a way that I have no control over the other resources that are available for, in this case, laparoscopic training. As we have control over the VR side of the training, where they're going to do it, and we're going to figure out what they're doing and how many times they've done it and when they did it. So I'm going to finish with that, and we're going to move on to the next topic.
Great. Thank you very much, Neil.